issue today than it was even a year ago.
Absolutely. I just want to let you know, our division head, Wayne McCormick, wanted to be here, but he is on our, he's attending on the wards and is head round with the team during this talk. So,
yeah,
so you know.
I see him on the ferry, the Bainbridge ferry all the time. So if he wants to ask me questions, I know it's being recorded, which is great. But if he wants to ask me questions in person, he can just seek me out. He doesn't know what I look like, but I know what he looks like.
Well, now he'll know.
Oh yeah, they're post-call today. Yeah. Okay.
All right. Well, we could probably go ahead and get started. Quite a few people have logged on already. Welcome everyone to Geriatric Medicine Grand Rounds. We, as always, have a fantastic speaker today. We have Dr. Danielson, who's from Swedish Hospital. He is the executive medical director of Swedish Hospital Medicine, or at least was until he's in a transition period. He's now also medical director of the post-acute care services for Swedish Health Services. He founded the hospital medicine program at Swedish and has been with it and built that fantastic program over a couple decades. But today he's going to talk to us about hospital at home, which, as we were just talking about, is very timely, especially in the era of COVID-19. So thank you so much for coming to speak with us.
And thank you very much for inviting me to talk to you this morning about a topic I'm very passionate about, hospital at home. And you're right. I have, when we first engaged in the possibility of me discussing this topic, presenting this topic, I was in charge of hospital medicine, which I started after 20 years of running hospital medicine. I felt it was time for a change and a new challenge. So as of about 5-6 months ago, I stepped down from that role, and I'm just doing medical director of post-acute care services. Both of them are full-time jobs, so I finally came to my senses. It's great to be back in my alma mater, proud graduate of UW School of Medicine. I did my residency at Boston City Hospital, worked with some amazing geriatricians there, actually. And I think I am still the only real Swedish doctor at Swedish, having grown up in Sweden. So I have essentially 3 goals today. I hope to convince you that hospital home is indeed an age-friendly model of care, and that it is safe to provide hospital-level care to patients in their homes, and that this is a model of care that is coming to the United States. I have no conflicts of interest and no disclosures, fortunately or unfortunately. We might want to start with a definition of hospital at home. So hospital home provides hospital level care in a patient's home for patients with suitable diagnoses and appropriate degrees of acuity. So this is for patients we would normally care for in a medical ward, not ICU, not telemetry. But it's important to note that these patients meet inpatient criteria. And that we talk about a hospital home, we talk about 2 different models. The substitutive model is where we meet the patient in the ER and the hospitalization is averted altogether. The early discharge model is one where patients are admitted for 1 or 2 nights in the hospital, stabilized, and then discharged to home to complete the hospitalization in their home. So it's essentially about bringing all the usual hospital services into a patient's home: physician and nursing care, IV medications and fluid, oxygen and respiratory therapies, basic radiography, ultrasound, DME, skilled therapies, and more. So many people on the call have probably cared for, say, a patient with community-acquired pneumonia in the hospital on a medical ward. When that patient presents to the ER, they're often very sick. They have fever, cough, shortness of breath. If you've ever had pneumonia, it feels like you're really put on your back and they may have multiple infiltrates, elevated inflammatory markers, and they meet inpatient criteria. When we admit that patient with community-acquired pneumonia to the hospital, once a day we typically bring a critical intervention, namely IV antibiotics. The rest of the time, that patient is spending their days in an uncomfortable bed, getting their sleep disrupted, often, if they're elderly, acquiring delirium. This is the type of patient that we can very easily, very readily, very safely care for in a hospital at home model. So I hope to convince you that this is a safe model of care. We actually have pretty robust data from the last 20 years with dozens of randomized controlled trials and 2 meta-analyses that show, basically in summary, that patients who receive care in their home have a lower 6-month mortality rate, a lower readmission rate. There's a decreased incidence of delirium, falls, and adverse events. Nosocomial infections, of course, go out the window altogether. And typically also, in this model of care, there is less caregiver stress, and patient satisfaction tends to be sky high. So let's look at some of the literature in detail. So the first meta-analysis that was published came out in 2009 by Sasha Shepherd of UK, University of Oxford, and others. They looked at randomized controlled trials, substitutive care, again, avoiding hospitalization altogether. Their study included 844 adult patients age greater than 18, with 440 of them in the hospital home arms. The most common diagnoses were COPD, community-acquired pneumonia, stroke, cellulitis. And the statistically significant findings in this meta-analysis included a 38% lower mortality rate at 6 months for hospital at home, higher patient satisfaction, lower length of stay, and fewer patients in the hospital home arm were discharged to an institutional setting. In a sub-analysis of one trial in that meta-analysis involving patients with dementia, those patients who were treated in the hospital home had decreased problems with sleep, a lower incidence of agitation and aggression, and less problems with feeding in that sub-analysis of patients with dementia. And I think as geriatricians, this makes perfect sense to you from your experience. In 2012, a second meta-analysis was published by Gideon Kaplan and his group out of Sydney, Australia. They also looked at this randomized controlled trials, substitutive care, much larger study, almost 7,000 patients, aged 16 years of age and older. And a broader range of studies were included, not just medicine patients, but also surgical, rehabilitation patients, and even one psychiatric study for hospital home patients. In this meta-analysis, the statistically significant findings favoring hospital in the home, which is the preferred terminology in Australia for this model of care, hospital in the home. Those patients had a 19% lower mortality rate, 25% lower readmission rate. The cost was lower, 73% of the cost of caring for the patient in the hospital. And 21 of 22 studies favored hospital in the home for patient satisfaction, and 8 of 11 studies favored hospital in the home for caregiver burden. More recently and closer to home, in 2018, the group at Mount Sinai published their results from a CMMI grant in the amount of $10 million that they received in 2014 to study hospital at home, and their model included substituted care, the acute phase of the hospitalization, plus a 30-day post-acute care period. There are 507 adult patients, 295 in the hospital home arm. And the hospital home patients it's an observational study. It's not a randomized control study. But the hospital home patients were older, 77 years of age versus 72. And hospital home patients were more likely to have at least one pre-acute functional impairment, 72% versus 56%. There was no difference in the percentage of patients with pre-acute poor general health, still pretty high, 63% for hospital home and 65% for the control arm. In the post-acute period, nurses and social workers provided self-management support and coordination of care. The four most common diagnoses were familiar to internists: UTI, community-acquired pneumonia, cellulitis, but they included 19 total diagnoses. Others included COPD, asthma, hyperglycemia, hypertensive urgency. And the statistically significant findings at Mount Sinai favoring hospital at home included a lower length of stay, 3.2 days versus 5.5 days, and a lower 30-day readmission rate, 8.6% versus 15.6%, and a dramatically lower rate of patients transferred to SNF, 1.7 versus 10%, and that's probably due to the 30-day post-acute care period that they included in this model, and also greater patient satisfaction, where 68% versus 46% rated their care at the highest level possible, the top box score. In late 2019, David Levine and his group at the Brigham published results from a randomized control trial involving substitutive care again. It was a small study, only 91 adult patients, and I think there were 48 in the hospital home arm and the rest in the control arm. They had intended to enroll 120 patients in this study, but the interim results were so favorable that the hospital leadership asked to terminate the study prematurely so they could expand this model of care to enroll more patients and provide greater hospital capacity, because Brigham and Women's is always full for good reason. There are a broad range of medical diagnoses: infections, COPD, again, heart failure, asthma. And the findings included 38% adjusted mean lower cost. Again, a lower readmission rate, 7% versus 23%. Interestingly, hospital home patients spent less time lying down, only 18% of the time versus 55% of the time in the hospital. And we'll talk more about that, how they captured that data. But surprisingly, despite the fact that they were more active, there was no difference in the instrumental activities of daily living, no difference in patient satisfaction. I would say kudos to Brigham and Women's. The control arm also rated the level of care very, very high, as did those who received care in the hospital home arm, but there's no difference. And there was slightly lower incidence of safety events in the hospital home arm, 9% versus 12%. Just a few months ago, the group at Atrium Health in the Carolinas published their prospective case series of essentially describing a very rapid deployment of a virtual hospital. Very impressive. They stood this hospital up in the middle of the pandemic, the virtual hospital up in 2 weeks. They were able to do that because they had a lot of the required elements of hospital home already in existence and deployed for other uses. And this study took place over 6 weeks, and despite that short time period, they were able to enroll almost 1,500 patients, all COVID positive. There were two arms: a home monitoring arm for patients who did not meet hospital level criteria. Those patients were provided a thermometer and a pulse oximeter and monitored by nurses and nursing assistants 24 hours a day. And then there were 180 some patients who received care in the virtual acute care unit. Those patients met inpatient criteria. So in the home monitoring arm, almost 1,300 patients, 3% of those COVID positive patients required transfer back to the hospital. And there were 2 deaths. Both of those occurred among the 40 that were in the the number of patients that transferred back to the hospital. So there were in-hospital deaths. And interestingly, Providence, which is Swedish is part of Providence, we also have a COVID home monitoring program, and to date we have enrolled over 15,000 patients across our system, covering 7 states, 51 hospitals, and our transfer rate to the hospital is identical to what they had at Atrium Health. 3% of those patients are also given a thermometer and a pulse oximeter, are transferred back to the hospital for a higher level of care. Very, very popular program, by the way, in our system. In the virtual hospital arm, with 184 patients, the findings included 13% of patients, a total of 24, required transfer back to the hospital, and 10 of those required ICU level care. 22% of the patients required supplemental oxygen. Same percentage required nebulizer or inhaler treatment. 11% required IV fluids. And interestingly, there were no deaths among this group of 184 patients, COVID positive, who met inpatient criteria. So the data in support of hospital home the last 20 years is pretty robust. So why have we not seen more widespread adoption of this model in the United States? Well, there are a number of reasons. First and foremost, there's a lack of payment mechanisms in the fee-for-service world for hospital home. That may very well change, and we'll more about that soon. There's a low penetration of population-based payment systems in the United States, and it's no wonder that in countries with universal health coverage, with national health plans, this model has been in use for quite a while in countries like Australia, UK, France, Italy, Spain, Israel, and it's growing there as well. We also have in the United States a long-standing focus on facility-based care, and there's a lot of inertia to overcome that, and a lot of entrenched interest, quite frankly. But also, there are countervailing forces that are making organizations take a second look at this model of care. And finally, the standing up a hospital program is pretty complicated. It's not done, at least not from scratch, in a fortnight. So there are several factors, I think, favoring hospital home adoption in the United States today. So a few years ago, in the fall of 2017, an advisory committee under MACRA, it's called the Physician Focused Payment Model Technical Advisory Committee, it's a mouthful, PTAC. They studied a number of practice innovations and provided recommendations to the Secretary of Health and Human Services. And they specifically evaluated the Mount Sinai model of substituted care followed by 30-day post-acute care. And they unanimously recommended to the Secretary of Health and Human Services that CMS start paying for hospital at home. So following that event, there was a lot more interest in hospital at home from healthcare organizations, payers, organized medicine, and even venture capital firms. Further, in support of hospital at home in the United States, is that we've had a gradual transition from fee-for-service to value-based care in the United States. And that, led by CMS, is only going to continue to increase in the next 5 years, which I think is a great thing, because it allows organizations to be much more innovative if they have payment systems that at least come close to population-based payment systems. And then the day before Thanksgiving last year, this bombshell came out that CMS came out with this hospital at home waiver. It's an expansion of the hospital without walls waiver that had been launched in the spring. And essentially CMS created a new program called Acute Hospital Care at Home, and with an explicit and detailed application process. This was a major event. I just about fell off my chair when I saw this, and many of you on the call probably know Bruce Leff, but he sent me a link. I've gotten to know him over the years. He sent me a link shortly after, minutes after this came out, and just in the subject line was "buckle up." And I think this is as I see it, once in a generation opportunity provided by CMS to really launch hospital at home. And CMS wants serious healthcare organizations to do this, to demonstrate that it can be done. The application process is not very onerous. It's fairly extensive, but it's not onerous. And they're keen on getting the evidence that this can be done, hopefully to build then a model for payment for the Medicare fee-for-service patients long-term, not just during a pandemic. So at the time of the waiver, CMS consulted with a number of stakeholders when they created this program. And there were 6 that were granted immediate approval to do this because they had done this before, including Mount Sinai, Presbyterian, Brigham, and you can see them on the left. And as of 2 weeks ago, there were 60 hospitals that had, or 60 hospital systems that had applied for the waiver, and I'm sure that number is much higher. I know it's much higher today, but I don't know exactly how many organizations that have applied. But it's a very exciting time for those of us who have been interested in this model of care for a long time. So while the CMS waiver will, I think, provide an immediate boost and a robust payment mechanism, so hospitals will receive the full DRG payment when they care for a patient in the hospital at home, just like the same amount of money they would collect if they had cared for that patient in the hospital. I think there are other forces, though, that had been in favor of hospital at home for quite a while. And I don't know who said it, but it's a truism. Demographics is destiny. Demographic changes often drive societal changes. And we do have an aging population, means great job security for geriatricians. We'll have 70 million people over 60 years, over 65 years of age by 2030. And also, as everybody on this call knows, healthcare in this country is extraordinarily expensive, and there's intense pressure for healthcare organizations to reduce the cost while increasing the quality, or at least maintaining the same quality. So I think these two factors, demographics and the fact that there's so much waste and there's so much such a high cost to delivering healthcare in the United States, are providing there's strong drivers of change and definitely favoring hospital at home. So, excuse me. Wanted to compare the hospital at home programs that were in existence 10, 20 years ago in the United States compared to what we're looking at today. And there weren't many 10 years ago or earlier than that, but there were a few, particularly in the VA and Presbyterian and other trailblazing organizations. Earlier programs were really outgrowths of home-based primary care departments, and they're staffed by geriatricians predominantly. also by internists and family medicine docs, but predominantly by geriatricians. Today, the growth is really emanating from hospitals, and more and more programs are staffed by hospitalists. Earlier programs had a low average daily census. The newer programs are poised for a larger scale. And I will say that there's quite a bit of hype here. Various actors in this space are, saying or claiming that they can take care of 20% of patients that are currently hospitalized. The consulting firm that is used by many not-for-profit organizations called SG2 upped the ante, said that in 5 years, 28% of patients who are currently hospitalized in the United States will be cared for in home and community-based settings. And when I was at the first International Hospital Home Conference in April of 2019, there was a Deputy Minister of Health from the Netherlands who declared that in Holland, they've set a target of moving 40% of patients from hospitals to home and community-based settings. I think there's probably quite a bit of hype, but I would maintain that even if we're able to move 10% of patients who are currently hospitalized into home and community-based settings, and I think we can quite readily do that, that's a paradigm shift. By the way, the second International Hospital Home Conference is a virtual conference this year in April. It's hosted by a group from Vienna, but it was a fantastic meeting, 2 or 3 day meeting in Madrid, and I suspect this one will be great as well, just an FYI. Earlier programs also had low enrollment from the emergency departments and less emphasis on technology. Today, the substituted model where we meet patients in the ED is in the front seat, and new models are embracing technology and telemedicine. So I mentioned earlier that setting up a hospital home program is pretty complicated, and there are a lot of operations and supply chains that need to be in place. So you need to meet the patient's pharmacy needs, both oral and IV medications, DME, need to be able to provide stat IV access and meds, stat labs, stat mobile imaging. But there's remote patient monitoring technology, and we'll talk more about that in just a bit. They're often driven by command centers where the RPM data is coming in and it's monitored by doctors and nurses. Paramedicine teams are involved, responding urgently to patients' needs 24 hours a day. And then you need to provide the usual skilled nursing and therapies, PTOT, speech, etc. in the home. While a lot of the follow-up visits in hospital home programs today are done using telemedicine, there are times and there are programs where LIPs, be it physicians or nurse practitioners, are also visiting the patient in their home.
It looks like there might be a question from Dr. Ong.
Yeah.
Hi, Per. Thank you for this presentation. There's this this list that you provided, and it's interesting that on your earlier comment, you had stated that caregiver stress decreased, which I find kind of surprising. Actually, is we're shifting the care basically to caregivers at home. And maybe if anything else during this pandemic, it has maybe highlighted the juggling that many of us do in terms of not only doing our job during the daytime, but also caring for our children at home now when they're homeschooling. And so, and including that and the caregiving burden, I find that incredibly surprising. And I am a staunch proponent of hospital at home. I think it's definitely something that is viable and open for a population, but for individuals who have a lack of caregiving or social support. It just seems like we're shifting the move to the caregiving burden to families. And if there was ever a cost analysis of the productivity that is lost from that.
Oh, yeah. A great point. I guess I would say that a lot of these patients are already being cared for by family members in their home. They have some need. And I think the caregivers are appreciating the fact that we bring all these services to their home. And also, I can't tell you how many times I've talked to frustrated family members, as a hospitalist for over 20 years. At Swedish, and I'm sure I know it's true in the UW system, you have a lot of patients from coming quite far away from the hospital. So they have to drive into the hospital, pay for expensive parking, at least here they do, and many facilities they do, and then navigate up to the hospital. They may or may not see the physician, because the physician may have rounded already and they're too busy to see them again. Personally, I've called family members who I missed many times, in the evening, and having to apologize that I didn't make it to the patient's room during my busy day. So I think there are a number of factors that come into play when patients are saying that there's less caregiver stress. And yet, I can see where one might think it might be counterintuitive because there's more work here, but I think they really appreciate not having to drive in, pay for parking, and then it's hit and miss whether they actually see a doctor. Whereas with hospital home, certainly when they have virtual access, telemedicine access, they can talk to the physician many times a day, actually. So I hope that answered your question. Also in the hospital at home, we intend to provide specialty consultation by cardiologists, ID docs, psychiatrists to select patients using telemedicine. A big component is the EMR integration, which can take months and can be quite complicated. And they need to provide meals and transportation to these patients as well. So I thought I'd spend a little time describing our model, which we've been working on for a longer period than I care to admit. Providence in Swedish does a lot of really, really good things that I'm very proud of. We're not the most nimble, but we do have what I feel is a incredibly detailed and well thought out plan. And we are going into the hospital home space. And we've gotten tremendous support for our model and our work. So today, when a patient presents to the ED, the ER doc knows that the patient is going one of two ways. They're either going to be discharged home or they're going to be admitted. With hospital home, there's a third option. For patients that meet inpatient criteria, they will be given the option, and it's always, I think this is important, voluntary. They'll be given the option of being treated in the home or being admitted upstairs to the hospital. Worldwide, when patients are given this choice, the acceptance rate tends to be very high, 85, 90%. In some of the American studies, and I'm not sure if it's because there are these patients are living in Manhattan and Boston, and they're used to having access and being hospitalized in first-rate hospitals. That the acceptance rate has been lower than that. But I think also the model is new in this country. And I think it also depends on how you present the option to the patient. But the patient will sign a consent to receive care in their home. And then they will be discharged from the ER, and the acute phase will start. And we're also planning on using a post-acute phase with less intense monitoring of patients in our model. I think the key to doing this safely is careful patient selection. So we have developed a number of inclusion criteria, both sort of universal to the hospital home model, inclusion and exclusion criteria, as well as disease-specific criteria. And we also have developed social or environmental criteria to make sure that the patient has a home that is safe and suitable for hospital home. So the sort of general medical inclusion criteria are pretty basic. The patient's diagnosed with a suitable diagnosis in the ER and meets interqual criteria for this diagnosis. And any secondary active diagnosis is mild to moderate in severity, either elevated glucose or mildly elevated creatinine. Then they would be offered this option of being treated in the home. And they can't be, floridly in respiratory failure. And we have a pretty long list of exclusion criteria. I don't need to read all of this, but if a patient has active GI hemorrhage, they may need endoscopy likely, and they belong in the hospital. If there's a need for telemetry, they should be in the hospital. Severe acute kidney injury, same thing, should probably be in the hospital. Now, and there are a number of other, significant psychiatric comorbidities, a really unstable psychiatric condition, probably not appropriate. Interestingly, at Mount Sinai, one of the arms that they have is what they call hospital averse, hospital at home. So for patients who really do not want to be admitted, but they also want care, those patients accept a little higher risk for the benefit of being treated in the home. So I was just on a webinar with Mount Sinai yesterday, and they had a patient with dementia, and the husband did not want his wife to be admitted to the hospital. She's had such bad sundowning in the hospital before that he insisted on being treated in the home, and they enrolled her in their hospital averse hospital at home program. This is a very busy slide. I don't intend for anyone to read it all, but it's just to illustrate the number of safety checkpoints that we've created in our models. If a patient presents with CHF to the ER, and the ER doc determines patient warrants inpatient admission, they start to socialize this concept with the patient, ask them if they're interested, and then the command center gets involved and screens the patient, looks at the diagnostic data available in the electronic medical record. If that looks okay, a social worker will also screen the patient for their home environment, make sure that's suitable for a hospital home. And hospitalist who works in the hospital will then go to the ER and do a consultation, and that note will serve as the HMP for the hospital at home. They'll sign the consent to be treated at home. They'll be discharged home, and within 2 hours, they'll be met by a home health nurse who confirms that the patient has a safe home environment, sets up the remote patient monitoring technology, and interfaces with the command center. And the command center takes over the care from there. So our model is centered around a command center staffed 24/7 by doctors and nurses. In our case, it's going to be hospitalists. They are part of a new multidisciplinary team. They're handpicked docs, handpicked nurses. So we're using home health nurses. We're planning to use home health nurses, but only those that have recent acute care experience. And I think not every hospitalist is suitable for this type of work either, even if they don't go out to patients' home. I think there's a different etiquette. Many people on the call, being geriatricians and trained in home-based care, know that there's a different etiquette in taking care of patients in the home versus in the hospital. And the nursing staff, who's the appropriate nurse to provide this level of care, was a huge topic of discussion at the International Hospital Home Conference, many programs favor hiring former ER nurses, sort of jack of all trades, used to seeing sick patients, can handle a lot of skills, but also nurses from with previous experience in the ICU or med-surg wards are appropriate for this level of care. We've had discussions with a number of payers, both our own Providence Health Plan and other local payers who are intensely interested in this model, want to collaborate with us, want to support us, including restructuring contracts to include a bundled period of 30 days after the hospitalization. We mentioned the supply chain that needs to be set up, and all of these systems, the technology, the staffing, supply chain, needs to have backup systems, and it needs to work on a timeline that's more like what we see in the hospital, not the typical home health supply chain, which works on days rather than hours. We will also have contracts with community paramedicine professionals who can respond quickly to urgent issues that come up for the patient 24 hours a day. The paramedics can interface with the command center and hopefully institute interventions that allow the patient to remain in the home. We are going to provide patients with a tablet that allows them to have 24-hour video access to the command center, Bluetooth-enabled pulse oximeters, blood pressure cuff, thermometer, and we're also going to put this small patch. It's a lightweight patch that goes in that left upper chest that captures a lot of data. Continuously monitors the patient's core temperature, their pulse, their respiratory rate, how many times per hour the patient coughs, sneezes, or vomits. It can detect falls, how much the patient is sleeping, how active they are at home, and that's another benefit of hospital at home. And you all know the benefits of mobility. It's one of the 4 M's, of course, and patients in the home tend to be much more active. We know that is good for promoting recovery from illness. Can even detect if the patient is walking with a limp. So this provides a lot of data, continuously updated and fed into the command center every 10 minutes. So I think, you know, many of these patients will actually be monitored more closely than they are on a medical ward today with this type of technology that is now available. So as I mentioned, we're looking at the yeah, was there a question?
All right, yeah, there's a question. Mayreed has a question about the number of providers and staff needed per patient admitted.
Yeah, so it's interesting. This is, you know, it's a relatively new model in this country. So in the Brigham study, the general internists and hospitalists caring for those patients, they had a maximum census of 4 patients. In the Atrium Health, the attendings were responsible for 12 to 13 patients. We think we can have, while we're going to start low because we haven't done this before. I've done it a lot in my head, but we've never actually done it. And so obviously there's so many factors that need to fall into place. So I think initially one doc will manage 6 patients, but we think that it's possible that in a 12-hour, say, hospital shift, a doc can manage 12 to 16 patients eventually, once this is a well-oiled machine, but that remains to be seen. Nursing care, also different in different models. And it's probably going to be in the command center. It could be that they're seeing between 4 and 8 patients. It depends on the level of engagement and how often the nurse is rounding on the patients, and also depends on how much support they have. If you have a fully integrated EMR that functions seamlessly and captures and tracks a lot of the data, it's a lot easier and allows you to see more patients than if you have a more clunky version where there's a lot more bird dogging of data, etc. So I think that's going to evolve over time, what best practices are. And in the CMS waiver, they specify that the patient needs to be seen in person by a nurse twice a day, and by a clinician, a doc or a nurse practitioner, at least once a day, just like they are in the hospital today.
Maybe one more question, and then I know you have the rest of your talk to give, and we could probably save a lot to the end. But folks are wondering if you can be in an adult family home and participate in this program, and similarly assisted living.
Great question. Yeah, so this great segue to this slide, actually. So initially, we're looking at patients have a bona fide home coming only from the ER. In the future, we will take patients in the early discharge model coming from medical and surgical wards, from SNFs, assisted living facilities, and adult family homes. Can also be receiving hospital home, absolutely. Patients on home dialysis, rather than going to the ER and being hospitalized, could receive their escalation of care in their home. And in the future, we'll also take patients from directly from primary care clinics and specialist clinics. But initially, we're starting in the ER. But absolutely, patient in assisted living and adult family homes could definitely be receiving adult family home if other criteria are met. So I'm working with a group within Providence that's housed in telehealth. So one of my partners is Dr. Todd Sartosky, who was actually at Harborview for many years. He trained in neurology and infectious disease. He's been a Swedish in Providence for probably 10 years or so. He's the head of all of telehealth for Providence. And we see hospital home as one suite of services on a continuum of services providing telehealth. So we have virtual visits today with primary care docs seeing patients in their home. We have virtual urgent care. We have remote patient monitoring for particularly frail patients with chronic conditions. There's acute telehealth using video communication between clinicians and patients in the hospital setting today to preserve PPE. On the far right, there's the virtual ICU, which we've had for about 15 years at Swedish. And then, of course, the hospital at home, which is part of the continuum of care of telemedicine, which has seen such a dramatic expansion in 2020. So once we have this chassis built with the command center, the providers in the field, skilled acute care nurses, physical therapists, etc., the supply chain is well oiled, then we can expand beyond hospital home to create SNF at home programs, the longitudinal care particularly for frail elderly patients. If we can keep tabs on them and continuously monitor their temperature, respiratory rate, and heart rate, we can intervene at an earlier stage before they need ER level care and send a mobile healthcare team out to provide interventions that allow them to stay at home. Our oncology colleagues are very interested in this model of care and see huge potential. Again, home dialysis patients is another area of growth. And I think also for hospice patients, what we ask family members to do now caring for loved ones who are in hospice can be a little harrowing. It's not always a pretty sight. And I think it's kind of crazy what lay people are asked to do. I've been in hospice situations myself, and I've lots of experience taking care of sick patients, and I know how to titrate the meds. For a lay person to do that is a little daunting. If we can support them while using telemedicine, I think it'll be a tremendous service for patients and families. So I see lots of opportunities for geriatrics and geriatricians in hospital home. I did write an opinion piece with Bruce Leff 18 months ago, arguing that hospitals should step into this space. But we also said they really ideally should partner with geriatricians, because you're the only professional group trained in home-based care. I think hospitalists have a lot to learn from you. In the future, most patients in a hospital home will still be elderly, just like they are in the hospital today. I think there's tremendous opportunities for research in this field for geriatricians and all clinicians managing patients. So those are my slides. We have a few minutes for discussion, and I'm supposed to leave this up. I think this code will take you to an evaluation.
Yes. Great. There was one question that we didn't get to yet from Dr. Ong. He was wondering if you see disagreements between family and patients about whether to participate in hospital at home. Like the patient wants to do it, but the family member doesn't, for example.
Oh, I'm sure that's going to come up. Yeah. I mean, we've all seen patients dropped off at the ER, and the family member just needs a break many times, or they head for Hawaii or Mexico while grandma is being cared for in the hospital. That's not going to change. But I think in a lot of situations too, family members are providing a significant amount of unpaid care today. And I think they will greatly appreciate, this suite of services and the technology that we're bringing to the home, allowing their loved one to stay at home and get a high level of care. And I see another David Grunewald raised the hand. Go ahead.
Thank you. Thank you. This is a wonderful talk. And from the VA side, I'm thinking of Scott Mader's work some time back in Hospital at Home, and reflecting on the list of participants that you show today. And I don't see the VA on that list, and I don't see Kaiser on that list. And it seems like these are two major organizations that would have a natural incentive to be involved at the front of the pack in rolling these kinds of initiatives out. And of course, there's inertia and infrastructure, but the incentives otherwise would seem to be aligned. And I wonder if you might reflect a bit on these organizations and where they stand in this in 2021.
Absolutely. Yeah. So I wrote the first proposal for hospital home for Swedish back in 2013. And I interviewed directors of 3 programs, Presbyterian in Albuquerque, and 2 VAs, Boise and Portland. So the VA actually had the majority of hospital home programs 10, 15 years ago in this country. They were small, but they were very popular with patients. And you're right. I mean, it's essentially like a mini nationalized health plan. They have all the incentives in the world to provide this care. And I know also from talking to the docs who provided that care in Boise and Portland, it was hugely successful and hugely popular with the VA patient population. So I don't know if there's more of a national effort within the VA system to launch hospital at home, but there should be. And with regards to Kaiser, yes, they have partnered in Oregon and in Northern California with Medically Home, which is an organization that provides sort of a turnkey solution to many of the supply chain logistics that are required. And they are going full force, at least in Northern California, and in Oregon. I hear it's on its way to Washington as well, which is no surprise. It makes very good sense for an organization like Kaiser.
Thank you.
Is there any talk at the University of Washington to launch a hospital home program?
You know, there's been early discussions, but nothing concrete yet. I think
Okay.
that there's some obvious roadblocks, of course, as you probably already know.
Yeah.
Right.
Our clinic structure, at least on the senior care side, and then Ton could talk about the post-acute care side. For senior care clinic, it's a DHF model. So that means direct hospital funding. So we're allotted a certain amount of funding, but a lot of that is still dependent on facility fees and other sort of things that we think are going to go away. So we do home visits, and I've treated a couple of patients with heart failure in the home, but I agree with Ton's perception that a lot of the times that's the caregiver really has to be a part of that. The other thing is a lot of the assisted living facilities that we work with, especially like Park Place, and would not agree, I think in principle would really struggle with this model because of their liability and they're under-resourced, and unless the patient is on hospice, well, actually Park Place and some of those places could not even, I don't think would really want to participate even in hospice. So that's another constraint of a lot of our facilities that are on the assisted living side.
Yeah, I think it's going to take time also to, as this model gets more widely adopted. I think it's going to be there's going to be consumer pressure for organizations to offer this level of service, and I think the inertia that's out there in many fronts will gradually recede as the public learns about this model of care and its great outcomes, and for at least for select patients, there's going to be more and more pressure, I think, and hope for organizations to have these programs, to offer them to patients.
Well, we have a lot of questions in the chat. We can see, I'll just go in order. There's a question about, are there any data on provider perceptions or satisfaction?
Yeah, it tends to be very high. And I should have included that. Yeah.
That makes sense.
Yeah, physicians tend to, and nurses tend to really like this level of care. And typically what I find, I've given tons of presentations to Providence leaders, and clinicians immediately see, most of them anyways, a significant majority, see the appeal of this, and that this is the future and this is the way we're going to go. It makes good sense to a majority of clinicians, I think.
There's also a question about staff training and how much staff training is required for this.
Yeah, excellent point. I think before you open your doors, you need to do dry runs and ideally simulations on patients, and go through all the steps to make sure that everything's hardwired and working. A lot of organizations do telemedicine already, so I'm not sure that requires that much training. We started doing telemedicine admissions in 2010 here at Swedish at Ballard with outstanding outcomes. And we're still using telehospitalists supporting, I think, 9 or 10 smaller hospitals, some within the Providence family, some outside. We've signed contracts with us, and we admit their patients at night using telemedicine. So I think they're different components, but it is complex, and you need, like I said, you really need to have these processes hardwired, and I think ideally run your staff through some simulation before you open your doors for your first patient.
Well, we're right at 9 o'clock, and there are a lot of questions in the chat. Would we be able to to send you these questions.
Absolutely.
Great. I don't know, Diane, if you would be able to copy them from the chat. But anyway, we'll see if we can do that and get these over to you. And
Sure, I'll
certainly,
take care of it.
oh, great. Thanks so much, Diane. All right. Thank you so much for this fantastic talk and for sharing this innovation with us. It's really, fantastic, and things are changing really rapidly. It's really great to hear about what you've already done.
Entirely my pleasure. And if anyone wants to reach out to me, I'm at perry.danielson@swedish.org. Feel free. I can talk about this all day long. Topic I love. So thank you so much again for the invitation.
Wonderful. Thank you.